Hi guys, it's Professor Costa and I'm back with part 2 of caring for patients with impaired protection after tissue and organ transplantation. Okay, so a typical, I don't want to say typical anything, kidney transplant, they may not remove the damaged kidneys, they may simply graft the transplanted kidney. So just be aware that it doesn't remove, if you think about all the risk for bleeding, they may not remove the damaged kidneys, right? Oftentimes they will just graft the new kidney into place and it starts working. It really just needs a blood source, which is really cool about the kidneys. Unless the kidneys have been, removed from prior surgeries or so forth, okay? So they're going to do an end-to-side anastomosis of the renal artery, right? And then an end-to-end anastomosis of the renal vein, right? So this needs a good, thick, juicy source of perfusion and an in and out, and the kidney will actually start working during the procedure. So they start, they're not even done suturing the kidney in, and there is often urine formation, which is a really good sign, okay? All right, here's one of the many versions of a heart transplant. So, and this one, you'll see that the entire heart isn't actually removed. So they will simply graft on part of the heart to the existing vessels, or they can simply piggyback. They may have leave the client's heart in place and then simply place the second heart nearby. I know that's kind of weird to think about it. So the patients that have the additional heart, you'll actually see two EC, like you'll see it's a really funky rhythm on the ECG strip, because you'll see that the impulses are still firing in both hearts. Remember too that if we're suturing parts of the heart together from a donor heart to the recipient, that's never going to be re-innervated, right? So once the nerve is severed, it's never going to operate the same. And so things that we do that normally impact the nervous system control of the heart wouldn't affect this heart because it's not innervated to the central nervous system. It's going to have its own intrinsic rate. So usually, it depends on the donor situation, but it's usually lower in the 60s to 70s. And so the patient isn't going to be accommodated for exercise. When I climb the stairs, my heart naturally increases production and it raises its rate while I'm climbing the stairs. That's not going to happen here. So we're going to advise these clients to make sure that they move gingerly and allow for, their body to equilibrate, because they may never be able to allow for that quick burst. Remember, these patients are usually very compromised. So any cardiac function is better than what they had before, so they usually feel much better even with this effect. And this is only one type of heart transplant procedure. There are many, many, many others. So I don't want you to, they may dissect portions or, okay. Example of a liver transplant. Again, you're not going to be surgeons. I don't expect you to know all the nitty-gritty with every type of transplant. I want you to be able to recognize issues in a patient post-transplant. So they may do just a portion of the liver, or they may do the whole liver, depending on what's going on with the client and if there are other matches involved. But you can see why it's a huge surgery, because that section of the vasculature that goes through the organ is also transported, with the donor liver, right? So there's anastomosis. So there is a big bleeding risk here, all right? And we are dealing with the vena cava, okay? All right, so, and then here's a split liver transplant. Portion of a donor liver, a living donor, is removed. Remember, the liver is one of the few organs that actually regenerates. So for the donor, they would be instructed to be very careful for the next few months, like no alcohol consumption, no Tylenol, that sort of thing. Anything hepatotoxic would not be allowed while their liver regenerates and regrows, and it will do that, which is why the living donor is possible with liver transplants. And so, and that portion is then sutured into the recipient, okay? Okay. So another thing that we're going to be looking at, because it's so prevalent on the boards in HESIs, is bone marrow transplants. And you'll see this for the blood dyscrasias like leukemia and lymphoma, right? And before the infusion, the patient's own cells are destroyed, right? So we want to take over, right? So the problem with this person is something in their hematopoietic system, right? Something with their production of those cells in the first place. Maybe they have, a white blood cell cancer, or so we want to destroy their immune system, which is what we're doing. This is why, it's so critical that these patients stay in isolation during their recovery. So before the infusion, the recipient's own cells are destroyed with massive chemotherapy and or radiation, right? So they're completely open to all infection. And then the hematopoietic stem cell transplant is actually transfused, like a blood transfusion. So in the donor, they're going to do a needle aspiration in the hip, and they're going to remove, because it's a nice, for want of a better word, juicy area, ripe with bone marrow. And then it gets filtered, and then it's transfused into the patient. And what we're hoping is that the bone marrow starts growing within the recipient. Okay, so we can have autologous transplant. So that's when we're, and hopefully we'll see way more of this in the future for adults. Right now it's mostly for kids. Autologous is safe stem cells from cord blood from the patient's own cells. So there's a lot more people that are banking their kids' cord blood, because it's filled with stem cells, and those stem cells can be used for later on in life. Then there's allogenic transplant, which means that they're just transplanted from another person, a compatible donor, usually a sibling, okay? Or synergenic is an identical sibling, which, how lucky is that you have an identical twin and that they do not have the disorder you're being treated for. There is also another method for obtaining stem cells in lieu of the direct aspiration. So, instead of having that big needle put into your hip bone, there is a system where donor blood is microfiltered for stem cells. There's less pain for the donor, but there's a lot less stem cells. So they literally take you to, almost like a blood donation center with a special machine, and they literally microfilter that client's blood for brand new stem cells that are being produced. But you're going to get a lot less bang for your buck. But there is risk for infection and pain for the donor. So there are people that opt to do that. The typical where you're getting, the HSCT is more likely to come from a relative, because you do have to be an excellent match, though there is a network called the Match operated by the National Marrow Donor Program that registers potential donors. And I'm sure you've seen those on the news or on social media, where they have a child or a patient who needs a bone marrow transplant, and no one in their immediate family or siblings are a good match. And so they will publicize and have a donor registration event where everyone shows up and gives a sample of blood, and they see if they're, they get entered into the network, and sometimes there's a hit in somebody, maybe not the person at the event, who the event is for, but maybe someone, across the country, and you find out that you're a potential donor, and you can decide what works. Maybe you don't want to do the typical needle aspiration, and you don't mind doing the filtration process. Okay, so once this is transfused into the client, we're hoping for engraftment, and that's when the donated stem cells take, so to speak, like they take to the body. They don't get killed off, so they take to the recipient's bone marrow and they grow. This takes about 2 weeks, and during this time the patient is completely immunocompromised. All right. Unfortunately, if engraftment does not occur, then we have left this person again without any ability to make new cells or protect their body. And so this patient can die if engraftment doesn't take place, unless they have another compatible donation within that same period. All right. And some things that they may use blood, they may use bone marrow transplants for would be things like aplastic anemia, severe combined immunodeficiency, sickle cell disease, leukemia, lymphoma, those blood dyscrasias. So complications of stem cell transplantation, the most common one you'll see, and this is something I would know if I were a student, is graft versus host disease, which is a type of rejection. And we try to, now here's the fine line we play with this. We want that bone marrow to grow. And we know that when it grows, it's going to produce immune cells. So, but we don't want the immune cells attacking the host's, the recipient's body. So it's prevented with limited immunosuppressive therapy. So we want to limit the T cell activity without causing bone marrow suppression. And there's a fine line, right? Limited, here's another, I find this stuff fascinating, but limited graft versus host disease can actually be a good thing if it's used for treatment of leukemias or hematologic cancer. And what I mean by that is, like, for instance, with leukemia, if there's still some rogue cancer cells floating around in the recipient, the donor's cells may actually hunt down any remaining leukemia cells in the recipient's body, which is kind of neat. Here's the bad part, though. 15% of stem cell transplant patients die from complications because we're basically transplanting the whole hematopoietic system from one person into another. And we, unfortunately, the cells that are transplanted in have their own HLA. That's why we want a really, really, really good match. But even with the best matches, there's still a risk because they're like being transplanted into a system they don't recognize, and they may start attacking lots of things. Veno-occlusive disease, which would be blockage of the liver blood vessels by clotting and inflammation, right? Here's a rash that is seen with graft versus host. That's that typical presentation that would be something I would recognize as a student. And that is where the host, the recipient, the client that received the transplant, the graft is now attacking skin cells. So types of transplant rejection differ depending on how soon after and what part of the inflammatory process we're talking about. So I'm going to go over this on another slide. I'm just going to list these off. So we're going to talk about hyperacute, acute, chronic rejection, graft versus host, which we already talked about, management of transplant rejection, maintenance therapy, and then rescue therapy, right? So the type of rejection depends on the hypersensitivity reaction we're looking at. I know you love slides like this. Okay, so I would know this. And this isn't a new slide, by the way. You've already had this content when we talked about allergies way back when in 1020, in 2040 when we talked about cancers. You have to know the difference. So type 1 is that IgE-mediated hypersensitivity. And that's your typical allergy, right? So, you know, I have hay fever, and that's what we're looking at as a type 1 hypersensitivity reaction. Okay, so immunoglobulin induces, the AG induces cross-linking of IgE bound to mast cells and basophils or release of vasoactive mediators, yada, yada, yada. This includes, so those degranulation of the mast cells, we're looking at huge release of histamine, right? Which is why antihistamines work well for a type 1, okay? Then we have a type 2, which is the IgG-mediated cytotoxic hypersensitivity, right? So this is from that cell surface, all right? So one that you should know would be typical manifestations include blood transfusion reactions, right? So if you have a patient that has a blood transfusion reaction, we're looking at a type 2 hypersensitivity reaction, all right? Type 3 deal with immune complex mediated hypersensitivity, right? So that's where we get all of those lovely antibodies, right? So typical manifestations include localized reactions, right? So that would be like necrotizing vasculitis, glomerulonephritis, serum sickness, systemic lupus, all right? So those are all immune complex mediated hypersensitivity, right? And then we have type 4, and that's cell mediated. And the one you're most likely aware of would be if you got your PPD, you know, that skin reaction that we're looking for if we put the subdermal injection of the PPD, the tubercular, that would be a type 4 cell-mediated hypersensitivity. Though they're all worrisome when we have a cell, some type of graft or transplantation, but you'll see on the next slide what we're going for. All right, so there's two main types of rejection. Either the hosts, the person that got the recipient, either their immune system attacks the graft or the organ, or the immune cells within the grafted part attack the host, right? So there's either it's the recipient's body attacking the new tissue, or the tissue is attacking the recipient. Okay, so a hyperacute is an immediate, like super duper, like they're still in the OR, all right? That's how, when I mean hyperacute, right? So, and this is a type 2 hypersensitivity reaction, just like a blood transfusion reaction. It's immediate, right? And this is caused by accidental ABO blood type incompatibility. This is so rare. The workup that these people get for a new kidney or a heart, the amount of blood work and tissue cross-matching is unbelievable. But it's very rare, but it can happen. So clots form immediately and occlude the vessels to the graft. So it's just like a blood transfusion reaction. It's the same type of hypersensitivity. Unfortunately, there's no treatment to be done. The donated organ has to be removed. It's never going to work. It's going to get clotted right off. So that's hyperacute. That's like we start stitching it in and we see it's getting clotted off, and that's, again, a very, very rare issue. Okay. Acute is weeks to months, and that's the most common type. And that's the T cell mediated response directed against a foreign donor, right? So that's a type 4. And this is where we're going to give immunosuppressive drug therapy, right? And we're going to go over the drug therapies on another slide. Then we have chronic, which is months to years. And we're going to have some scar tissue. We know that anytime we have a boo-boo in the body or stitches or whatever, that scar tissue and fibrosis forms. Well, unfortunately, what happens is that the tissue in the grafted tissue or organ gets fibrosed. It gets changed over to scar tissue, and it's a combination of T cell and immune complex reaction. So it's a combination of type 3 and 4. So prevention is key, and it's the same drug regimen that we're going to use for acute, and unfortunately it may lead to eventual need for a replacement organ. All right, and then we have graft versus host. And this is most commonly seen in the bone marrow transplants. And usually you're going to see diarrhea, rash. That's the one that shows up the most on the boards, right? The rash all over the recipient's, torso. And jaundice, right? So we're going to see graft versus host. And how do we prevent that? We're going to be very careful, right? We want to make sure we don't destroy our chances of engraftment. And we want that new immune system to work, but we don't want it to work too well, right? So we have to be really, really careful with that, okay? Let's see. I think that's what I want on this slide. Okay, I would know this slide. I don't know how often, I would know this slide. These are the drugs I want you to know, okay? So we have two types of therapy. We have the maintenance therapy, which is continuous. When I say continuous, I don't mean like they're going to take this for a month and then stop. I mean, consider it like a diabetic that needs insulin and they're going to take it every single day for the rest of their life as long as they want to live. Well, maintenance therapy is the same. You are going to take continuous immunosuppression after a solid organ transplant for the rest of your life, which is why you have to be compliant with the therapy or be able to comply with therapy as well. And so this can include combinations right, of a calcineurin inhibitor, a corticosteroid, and an anti-proliferative agent, all right? Then we have rescue therapy. We have signs of something acute is going on. There's a change. So it's treatment of an acute rejection episode. And those include monoclonal, and polyclonal antibodies and maintenance meds at higher doses. All right. So almost everybody's on some type of steroid, right? So prednisolone or prednisone, and we know that steroids limit the immune response. You know that by now, right? So they broadly inhibit cytokine production in most leukocytes, resulting in general immunosuppression. So prednisone isn't just used for transplant rejection. So let's say we have someone with a lupus flare-up. They may be on a high-dose steroid. We have someone who has MS with a flare-up. They may be on a high-dose steroid. So this is high doses for short periods of time. And they may also be on a maintenance dose. But if they have a flare-up, or we have signs of an acute rejection, we're going to initiate rescue therapy, which would be higher doses than they normally take. Anyone that is on a steroid is at risk for infection. You know this. Anyone who's been a transplant recipient and is on any of these medications is going to be at risk for infection. And they also need to be taught about things like cancer risk and, making sure that they don't go, especially nowadays with COVID-19, that these patients are prime candidates for overwhelming infection, okay? And with the corticosteroids, also remember that we're limiting the entire immune response, which includes the gastric mucosa. So these clients are at higher risk for gastric ulcers, okay? Cyclosporin or calcineurin inhibitor. So this stops the production and secretion of interleukin-2, which then prevents activation of lymphocytes involved in transplant rejection, right? So you have to be careful with cyclosporin. You got to do peaks and troughs to make sure that the patient isn't becoming toxic, all right? Then we want an anti-proliferative, and this limits DNA synthesis and prevents cell division in activated lymphocytes, right? So this can cause bone marrow suppression. So we want to be careful with the I can never say the name, azathioprine. Tell you how often I give this. I don't treat a lot of these. I have had patients who've had transplants, but I usually I'm just giving them their maintenance doses. I'm not usually caring for acute post-transplant patients. So we would also we could also use a monoclonal antibodies for that rescue therapy, and that targets the activation of T lymphocytes, increasing the elimination, right? So we send those little bad boys in there and it gets rid of the T lymphocytes. And then we can do erythrocyte globulin equine or rabbit, right? So these are literally AG rabbit, or AG equine. AG rabbit is probably the one you'd see the most. And these are antibodies derived from other animals, right, that bind to and eliminate most T lymphocytes. So we give you something that's not going to hurt your body, but is going to attract the T lymphocytes like, flies on sugar, right? So we introduce something into your body that sucks up those T lymphocytes that were attacking you in the first place, and they stop a transplant rejection episode, okay? Which is kind of neat if you think about it. All right, so his Imuran, which is the azathioprine, I can never say it. Imuran is the brand name that most people have heard of. And we're suppressing the body's ability to defend itself. So these patients are immunocompromised, right? It's also used in autoimmune disorders for obvious reasons, and it's an anti-inflammatory, right? So make sure that you know this drug, all right? And that you have to check the patient's CBC to make sure that there's no bone marrow suppression. This can cause really bad blood dyscrasias. So you could have really weird platelet counts or white blood cell counts or be really anemic. So you have to make sure that they're monitoring the patient's CBC, okay? And it's also used to prevent transplant rejection, okay? It inhibits the protein synthesis to suppress cell-mediated hypersensitivities, right? We have to watch our client for infection. We have to make sure they're not having blood dyscrasias, and we're also watching them for signs of a organ transplant rejection, which is why they may be getting this, okay? Though you may also see imuran for those autoimmune disorders like rheumatoid arthritis or irritable bowel, like the Crohn's disease, right? And you want to watch for the neutropenia and thrombocytopenia. Okay. So nursing management, preoperative. Okay, so we have someone that needs a new organ or tissue. Therapeutic regimen and postoperative instructions. So the patient needs to fully understand the regimen before surgery. This isn't like buying a new car and you can bring it back if you don't like it. This is life altering. And the patient has to fully understand what that means. That they understand the medication and infection control. They understand that they're going to be on multiple meds every day for the rest of their life. And they have to be trained about what signs and symptoms of acute and chronic rejection are, okay? And they also have to be taught and go to, in many cases, they have to go to like family therapy or group informational sessions about the psychosocial adjustments. So patients have to learn not only about staying healthy, but how to adjust to being healthy. Even good change is stressful. Remember that. So their relationships with their family members after organ donation change. When the person's no longer the sick person in the family and they're more productive, people have, falling outs with kids or spouses or, brothers or mothers. The person is transformed when they're no longer, so ill, for instance, like with a heart transplant, they can barely even move, or they have an LVAD and suddenly they have a working heart and they can go out and do things and be more independent. That can really affect their relationships. So postoperative. All right, so ABC's here, right? We know they're going to have a risk for bleeding, and we want to monitor them and really be super vigilant about preventing infection. And I also want you to remember that they're at risk, all of them, for things like gastric ulcer, because we're limiting their entire immune response, which does include the gastric mucosa. We want to make sure they're maintaining the medication regimen, and we're going to reinforce that teaching with them over and over and over again. Okay, so for instance, if we transplanted a liver, signs of acute rejection or acute liver function decline, whatever, but usually a sign of rejection is a sign that the organ is failing again. So we want to monitor their liver function tests, right? Their LFTs, and we should see improving jaundice, right? So we want to make sure the new organ is doing what it's supposed to do. And if it's not, is it an infection, like just because it's a fresh post-op? Or did the graft die? Did the new liver not make it through the surgery? Or is it that the patient is rejecting it, okay? We want to monitor stuff like urine output and BUN and creatinine for the kidney. So those are the tests that would be done down the line as well. That patient would come in and they would have their BUN and creatinine checked. And if there's changes, then that could be a sign of rejection. We want to monitor improved cardiac output with the new heart, right? So we should have, if the new heart's doing its job, then we should have less crackles and less peripheral edema, right? And reduced work of breathing. I know someone that had received a new heart, and when he was still in the hospital following his surgery, his wife told me, he's like, yeah, my feet are hot, and he couldn't get over it. It was like they were warm. It was like making him sweaty, and his feet weren't used to being perfused. His heart was so not doing its job as a pump that his feet were just used to not being perfused. And suddenly he had a working heart and his feet were being perfused. And they were like, hey, what's going on? And it felt hot and it felt weird. Okay. So you should have signs of improved cardiac output with that new heart. We want to assess for signs of organ rejection, right? So the organ's function may start to decrease, right? So we may have a new liver that starts to fail and the patient's going to have jaundice. We may have someone with a new kidney and we see a bump in BUN and creatinine or a drop in urine output. Okay. Usually with organ rejection, remember, this is an immune response that's occurring. So people feel ill, like general discomfort. You feel achy, like flu-ish. They may have pain or swelling in the area of the organ, though not usually as common. They may have a fever, which is rare because remember, it's really hard for someone who's immunocompromised, because we've made them immunocompromised, to develop a fever. We've limited your protective mechanisms. So it's really, really difficult for a person who's immunocompromised to get a real high fever. So fevers are rare, but a low grade temp, anything like 100.5, that would be emergent for these clients, just like with our chemotherapy patients, all right? So flu-like symptoms, right, including chills, body aches, nausea, cough, and shortness of breath. So if we're making this person immunocompromised on purpose. Of course, the teaching would be, if you feel sick, you need to call your doctor and you need to get checked out right away. Is this an acute rejection? Is this a failure of your new organ? Or are you sick, which for these clients is emergent because they're immunocompromised? So long term. So obviously we want to make sure we're assessing them for infection. We want to assess for bone marrow suppression. So these people would have signs of bleeding or shortness of breath or fatigue. So they would get checked CBCs, right? We want to check, make sure those cells are doing their job. So they may become pancytopenic, meaning they would be anemic, they may be neutropenic, and they may be thrombocytopenic. And those thrombocytopenic patients would have risk for bleeding and bruising, okay? These patients have a huge increased risk of malignancy. And the reason for that is because we've limited their immune response. And remember, we have cells kind of patrolling our body at all times and looking for bad cells. And they kind of get rid of them through that, cell destruction that they do. Well, so we've limited their immune response, so they're at risk for things like lymphoma and basal cell carcinoma of the skin. Okay. We also want to assess for signs of prolonged steroid use. Remember, these patients are on long-term steroids, sometimes lower doses than others, and we may kick the dose up if they have an acute flare-up, right, for the rescue. So that includes gastritis, right, the gastric mucosa, peptic ulcer disease, bone weakness, GI bleeding, and steroid-induced diabetes. And we also want to worry about fluid and electrolyte imbalances, okay? And they want to avoid contact sports, right? Sorry, here's your new heart, but you're not going to be able to play contact football anymore, even if you ever did, okay? Teaching post-transplant malignancy, and this is not a small risk, all right? The gentleman that I apologize if there's anyone in class that knew this gentleman, but lovely guy, and he got his heart transplant. He lived for years following the transplant, got to see a lot of great life events and, really took advantage of it, but unfortunately ended up succumbing to another type of a cancer. So impaired protection increases the risk for many cancers. Risk for post-transplant is 4 to 100 times the general population, especially for skin cancer and lymphomas. So if you're like 100 times more likely than the general population to get a skin cancer, you need to be under the umbrella in a hat with long sleeves and sunscreen, right? So these patients need to be taught about not only how to prevent skin cancer, but also they need skin cancer teaching. I can't underscore this enough. You really have to teach your clients about this. And then they should also be screened for other common cancers. So if they're a male client, then they need to make sure, not only are we doing the CBC and we're looking for blood dyscrasias, and we're making sure they don't have signs of gastric, ulcers, but we also want to screen them. So if they're a man, we want to make sure they're getting their prostate checked. If they're a woman, they need to make sure they're getting their mammograms and pap smears and all that stuff. So they should be regularly screened for other common cancers, especially skin cancer.